You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Thank you for tuning in to our 2023 end-of-year recap. Point of Care Partners subject matter experts Pooja Babbrah, Pharmacy and PBM Practice Lead, Jocelyn Keegan, Payer Provider Practice Lead, and Kim Boyd, Regulatory Resource Center Lead, came together to discuss their own personal top 3 2023 health IT milestones, what they hope 2024 will hold, and perhaps most anticipated, the trio discussed the final version of the Interop 3, Advancing Interoperability and Improving Prior Authorization rule, giving insights and advice to listeners on how to approach the initial review of this important final rule. We at Point of Care Partners wish you all a happy holiday and happy new year. And don't forget, if you have topic ideas you'd like us to cover in future episodes, be sure to share them with us by emailing us at podcast@pocp.com or tweeting us at POCPHIT.
Hello, everyone, and welcome to our special year-end episode of The Dish on Health IT. Our regular listeners will know that we generally invite health IT leaders and trailblazers to break down and discuss some of health IT's biggest news and most exciting milestones. But this time we're doing it a little bit differently. Most of you probably know that here at Point of Care Partners, we have subject matter experts galore. So today we've got our group of POCPers to look back at 2023, as well as discuss what 2024 will have in store for healthcare stakeholders. So I'm Pooja Babbrah, the Senior Consultant and Pharmacy and PBM Practice Lead here at Point of Care Partners, and your host for this episode. And my co-hosts today are Jocelyn Keegan, who I'm so excited to announce recently was named Direct Trust Interoperability Hero, and our wonderful, always steeped in policy knowledge contributor, Kim Boyd. Kim runs our Regulatory Research Center and is responsible for the team that produces all of our policy subscription services, including the Interoperability Outlook. So 2023 has been anything but boring, and it's not over yet. The industry has been expecting a huge end-of-year bonus in the form of the final Interop 3, the Advancing Interoperability and Improving Prior Authorization rule. If you all remember, this was the rule that was pulled back, and we've been kind of waiting for this for a couple years now. And so in our special 2023 end-of-year episode, we're going to cover some of the top things that happened in 2023 and what we think will continue in 2024, and also briefly touch on the Interop rule that we're expecting. So before we jump into our discussion, I'd like to actually have Jocelyn and Kim briefly introduce themselves. But Jocelyn, I'm going to start with you.
Awesome. I'm excited to be here. It's actually really fun to get to co-host with you two. I'm so excited for the conversation today. So I run our payer practice. I'm our payer practice lead. And I'd say in general, I'm a devotee to all things positive change and really enjoy getting to build things that and focus on problems that haven't been solved before. I'm also the program manager for what started this idea of, copying and building on what Argonaut had been able to do within the FHIR world called Da Vinci. And I focus in our practice from a POCP perspective on payer provider collaboration, large topics around interoperability, and then workflows around interoperability between payers and providers like value-based care, prior authorization, and the related. So excited to talk about not just the 0057 final rule that Pooja referenced, but also I'd say a slew of regulatory activities that are headed our way as we close out 2023 and head into 2024.
Great. Thanks, Joss. Kim, you want to go and introduce yourself?
Yeah, absolutely. And Joss, it's been a while, but it's been a while since I've had to spend the holidays, right, looking at a lot of regulations, but I just feel it coming on, right? So I'm trying to push through and kind of get everything solidified before those rules drop. But I'm Kim Boyd. I'm lead of our Regulatory Resource Center team here. And as Pooja indicated, the team here in the Regulatory Resource Center side, we're the ones who pull together all of the policy-related detail that goes into our subscription services. I've been a member of POCP now it'll be 2 years. 2 years, 2 years today, as a matter of fact. And so it's always a pleasure to talk with both of you and be a part of this conversation. It seems like forever since we had a chance to be in the same room and have conversations. So I'm looking forward to this. We do have a lot on our plate, right, coming up, and that we help our clients with on an ongoing basis. And I think there's going to be more who come out of the woodwork after all the rules start to drop, right? But I would definitely be remiss if I didn't recognize you specifically, Jocelyn, and all the kudos that you've been doing and leading the charge in the payer practice side in that field. It really takes a special person, and not just anyone, who can channel their devotion to the positive change that we're starting to see and take it into tangible action. So kudos to you and the team over at Da Vinci and on many others for continuing to lead in these endeavors and paving the highway of progress for us here in healthcare. So I really appreciate your efforts.
Thank you. That's very nice. It's a team sport for sure.
Yes.
Yeah, thanks, ladies. And I agree with everything that Kim said. It's been amazing to watch Jocelyn and the Da Vinci team and everything you guys are accomplishing. So thank you for that. So I'm thinking for our format today, we spend the first half of our conversation just kind of doing a round robin and sharing our own personal top 3 events, happenings or trends that happened in 2023 before we talk about the big anticipated final rule. Of course, we have our 2023 trends article, which we will link in the show notes, which gives kind of all of POCP's perspective. But I want to just kind of, like I said, do a round robin. I can get us started on kind of the top 3 list and what's happened in health IT, and we'll go from there. So actually, Kim, I'm going to start with you in terms of your top 3 list of, kind of what were your top 3 from 2023, kind of good or bad?
Yeah, I kind of bucket it all. So healthcare interoperability for sure, right? And it's a big bucket of things, that were coming out of the 21st Century Cures Act and beyond, and all the activity, that we saw federally, the drop of the 2022 rule, the 57 rule, 57P toward the end of 2022. And there's all of the whirlwind that went around that and conversations in 2023. And this how this data integration needs to be fueled, right, and implemented. And I know Joss will probably touch on the FHIR ecosystem, but I think that holistically and how we're going to see the industry start to progress, I think at a greater speed than what we've seen previously. Definitely, and this is it's kind of a catchphrase that most people have used. It's been around actually in healthcare for a while, but artificial intelligence and machine learning and large machine learning, I think we'll see even more of that. We saw the HTI-1 rule come out and talk about transparency, right? That was driven towards some of those technologies that are being used in healthcare. And I think we're going to see, greater trends in that area of focus on that. And then, of course, I think telehealth. I don't think we can get past telehealth, telepharmacy. COVID-19 broke open the door for that. And I think we're going to continue to see that. So how do we converge? How do we start seeing that those digital applications coming into play through the telehealth platform? So those are 3 big ones for me. We touched on that many times in our interoperability outlook in different pieces, but I think we'll start to see even more, especially with the rules that we expect to come out. And what we're going to see happening this coming month.
Yeah, that's great, Kim. Thanks so much. And we'll probably come back and touch on some of these. Joss, how about you? What's your list?
So I'd say my list is complementary to Kim's, and maybe from a different slice, right? Because I've been sort of at this work around the clinical data exchange side of the world for quite some time. So I think that, to me, what has been meaningful about 2023 is we've talked about sort of moving into implementation mode, and the real world progress and adoption of FHIR starting to happen at scale is really starting to be felt and I think acknowledged and witnessed by folks. And we're seeing people make more progress. If they're not public and talking about what they're doing, you can tell that they're actively engaged and they've picked up guides and they're using them. And I think we could see that in two ways. The first is, I think the reaction to the attachments rule that dropped alongside the prior authorization and burden reduction rule last year is really telling, right? We came out this summer and heard from some of the major professional organizations, AHA and AHIP, and our colleagues at the American from AMA, really sort of joined hands and said, don't get in the way of the progress of what we're doing with APIs in real time. And I think the counterpoint to that was that we didn't really see, wholesale negative responses to the proposed interoperability rule. I think partly to Pooja's point, because we had seen a version of it and that version reflected, I think, some of the concerns around maturity of the work in progress and the guides. But I think that to me, having been one of the people that actually read all of the responses, right, because it's so near and dear to my day-to-day activities, was there wasn't a don't do this isn't the right way to do this. There was an acknowledgement of we need time to absorb it and to make it real and to learn as we go in the responses to the NPRM. I think that's really telling. The second thing I think that is important, and I agree, sort of this move around AI, but again, it's a topic that we've been talking about for a really long time. So I think the acknowledgement and the steps around HTI-1 and the industry conversation about sort of what is the built-in bias and how do we make sure that we have equity in the use of some of these advanced technologies, and maybe there's some flaws in the early data that they're being modeled on, I think shows sort of a maturity around the topic around AI, and I think that's important. And then I think the other thing for all of us, I think that have sort of been waiting, sort of on the sidelines watching is, what is TEFCA really going to be? What isn't it going to be? And again, tying back to the first topic, we've been waiting to see what is that alignment between the TEFCA infrastructure and rules and framework and this emerging API world and moving to more real-time interactions. And the acknowledgement that we really need to get alignment between the FHIR roadmap and the TEFCA roadmap. I think anybody that's seen Mickey speak in the last quarter, I think is hearing sort of really that push to make sure that that's a fast follow. And we're seeing early adopters in the candidate QHINs really trying to figure out what that FHIR or network FHIR solution looks like. So it really addresses scaling. And I think that in there is an important theme, which is I feel like the industry between the attachments responses and sort of this need to drive TEFCA to FHIR are really showing really the mature sort of advancing organizations acknowledgement that we need to get out of documents and get into codified data. And I think that that'll be an important theme as we go into 2024.
Yeah, absolutely. And I think, we've always said so many times on this podcast that, this isn't a sprint, it's a marathon, right? So I think that's what we're seeing, right? I mean, rules dropped. We saw some things pulled back. We're seeing progression. And I do love the fact that both of you brought in the AI aspect because, all of that swirling. I think every single conference we all went to this year, that was a big topic, but we're starting to see it kind of narrow, right? And I think that health equity bias is an important one on that. So I'm going to share my list. I love the fact that, we can all come up with different ideas and kind of top trends. It just shows how much is really happening in the industry. So, of course, my number one, I would say, is pharmacy interoperability. I think that's absolutely number one for me. I was honored to participate in the high-tech pharmacy interoperability task force. And, for years, we've talked about how important it is, how we can bring pharmacists in. I think a few years ago now, we had Steve Posnack on, and, I kept talking about pharmacy. And so it's nice to see that kind of finally became a reality in terms of getting a focus on it. And just some real momentum, right, of how you share data with pharmacists and how they get access to patient records. I know that Sequoia, right, the Sequoia annual conference was last week before, all about TEFCA, but we did have a panel on pharmacy interoperability. So I think that, especially going into 2024, we're going to see, I think, a lot of focus on that. And I'd say my number two, number three are kind of some new trends that are coming about. I think, we all talk about moving from fee to service, from fee-for-service to value-based care. And part of that, again, from a pharmacy perspective is pharmacogenetics, pharmacogenomics, doing that testing, right, to make sure the medications are working on patients. NCPDP held a stakeholder action group earlier in the year. We have a colleague, Kelly Petzold, who's an expert in that area, who's been on stage this year talking about that. And so, again, that kind of recognition, right, of course, we have providers and payers. We always talk about pharmacy the interoperability for that. Now we're finally getting to pharmacy interoperability and what pharmacists can do. And I think my last one is just digital therapeutics. That's a topic that, we at Point of Care Partners, we're doing some work around. Again, it's becoming actually a topic with payers. Are they going to cover them? Are they not? And so that's another area that I've been focused on that I think, there's been a lot kind of swirling in terms of trends, but I think we're going to start to see some real focus on how do we bring those into workflow and into the EHR and payer coverage of those types of therapies. So I think, those are really kind of my three. And I'm excited actually to share some of the digital therapeutics work that we're going to be doing in 2024 as well. So, all right. So that was our top three, I think, lists. Kim, do you want to comment or share any thoughts about either my list or Jocelyn's list? Anything?
They converge.
Yeah.
Right?
Yeah.
No, I think Pooja, you're spot on, right? That there's been kind of these two sides of the ecosystem in healthcare, for some period of time, where you've got pharmacy services and NCPDP and the standards that they do there. And they've been that 45 years, right? And we've all been in leadership there and progressing things under NCPDP. We've all now been in the HL7 realm and continuing to evolve how the fire ecosystem is going to work. And Jocelyn, you mentioned it, right? In TEFCA, right? There's still a lot of questions there, but I see this convergence starting to happen within, or at least the opportunity in where we need to have systemic interoperability across both of those ecosystems. And how is pharmacy interoperability, like through the HITAC, which again, congratulations for your leadership there. I think that was a really good task force and the recommendations coming out of there. I think you're going to continue to play into how does pharmacy continue to evolve and also interoperate around those specialty things that you're talking about that Kelly's so good at on BGX and on the digital therapeutics. And when a plan decides to cover it, how are we going to make sure that information is flowing in a way in which the patient can quickly get to that care and utilize that care, right? So I think, NCPDP and, the strategic planning committee, the board, and the task groups that are working on a lot of smart stuff around pharmacogenomics and around digital therapeutics and on social determinants, right, of health and this data that needs to flow. And I think FIRE is one of those key components that, that Jocelyn and the team have been working on the HL7 side.
Yeah, absolutely. Joss, how about you? Any comments on our top three?
Well, so I'll double down, right, on including the pharmacists in care and in care planning and in care delivery. Anyone over the last couple of years that's had the opportunity to engage with U.S. healthcare at scale understands how stretched thin everyone is. And I think being able to make sure that we can get the critical data at the right time to the right participants so that we can actually improve patient care. I think that's huge. It's long overdue. And I think previous to conversations we had, sort of in the early days of trying to move around this clinical data, I do think the technology is there and the regs to support that at scale, I think is happening. I do agree with Kim and you on sort of the PGX side of the world. I think there's probably some parallel with genomic testing there that I think that this idea of how are we actually doing care at scale around that's going to get paid for by the payers, I think is important. And I think we're going to see, as this convergence that Kim is describing happening, this ability for us to be able to crosswalk between standards. And I'm sure we'll get into that as we talk about 2024 more. But, technology is built to crosswalk from one standard to another. It being standard is what's important. Versus I think what we've dealt with is the standards have been more brittle in the past. And so there's been a lot of customization. So I think the more we can have flexible standards, the easier it will be for us to really be able to allow people to move across these different paradigms and different domains. It's great to see the pharmacy side of the world getting the recognition for the progress that has been made in automation, really compared to other parts of healthcare. I think that's really welcome. But I'm excited to see, the medical side and the, provider payer side of the world sort of get to parity. In addition, Kim, to your point, sort of the larger FHIR landscape, I think this ability for us to really be able to have other communities continue to sit on top of and step up and, get up to parity with data exchange about, some of the exciting work around public health, and with the CDC getting involved in APIs and CMS looking at really pushing quality measures into more of an API-based exchange. The more we can get data moving in real time or near real time, in handling and maturing sort of how to do that at scale at populations, I think the better off we're all going to be able to do to fix real business problems. So I'm excited.
Yeah, and I think, Kim, you know this well. We talked a lot at NCPDP strategic planning about, how do you bring pharmacists in, right? And I think, kind of incorporating them into an actual value-based care contract's not always easy, but, there are models that can be used, but it's like, how do you exchange that data, right? And how do pharmacists have access to that data? And I think this focus on, pharmacy interoperability, and it's not just for pharmacists, but for the providers too, right? To get to find out what pharmacists are hearing from their patient. I always use an example for social determinants of health, right? A doctor may have written a prescription for a patient who basically tells their pharmacist, the pharmacist says, hey, you need to refrigerate this. And they don't have a refrigerator, right? Because they're, in transition in their housing. And so it's things like that of not just, having the pharmacist, be doing those medication things, but what information can flow back to the provider as well. Even if they're not in a value-based care contract, there's information that should be flowing back and forth. So, definitely, it's been nice to get that focus. So, all right. Anything else before we move on to the big
scary topic? What you were just talking about, Kim. I'm sorry, Pooja. I think this point around the information that the pharmacist gets, because the pharmacist is the person that sees the patient often the most. It's not just about getting data back to providers. It's about getting data to the right person, right? So in that case, it might be, are there referral services? Are there support services? And how do we really think about that extended community care team? And I don't think that there's not a straight walk, right, of how we're going to get there. But I think being able to standardize the information, standardize the workflows so that it can be scalable across members of the provider or the care community that just are completely locked out of these workflows today because the barrier to entry technology-wise or investment-wise in some of these platforms is just, it's just a non-starter. And so I think that I was listening to one of my colleagues talk about, being inside of an internal meeting and trying to turn on new FHIR APIs. And she used the description of they sort of laugh when they get feedback from the developer, like, how long is it going to take to stand up the next payer that does this? And the developer's like, I think I need a week to do that. Whereas in the past, it would have been, this is a 9-month project, right? Of somebody coding and working on it, that it's just, the power of being able to get to the second, third, fourth, fifth user of this information in their workflow is just, it's going to operate like the rest of us rely on our technology today to get things done. So, it won't be easy, but the technology won't be the block. So I think that's important.
Yeah, absolutely. And I do feel like in 2024, we're going to see hopefully some progress on some of that community-based organization, and how do we loop them in as well. I think there's a lot of discussion around that.
Yeah, I think
there's a lot of focus around that, and for obvious reasons, right?
Yep.
Because it does take a community to help a patient.
Mm-hmm.
And it's not just one resource. But to Jocelyn's point, right, pharmacists do see the patients a lot.
They do.
A lot more than a primary care provider. So how do we, continue to move the needle on access, use, and exchange in a more timely manner? And I think we'll see a lot more of that in 2024.
Yeah, definitely. All
without
right.
the rules.
Yes. Speaking of rules. All right. So we're waiting. I think it's at OMB as of this recording of this podcast. So we're waiting for this new rule to drop. Earlier this year, I know we did a few webinars to provide kind of an overview of the proposed rule and also recap the comments. Since then, we've seen, kind of various policymakers speak at conferences, maybe tip their hand a little bit. And so what I'd like to focus on next is just, thinking about the NPRM actually, and talk about kind of the big things that were included, and, talk about kind of where we think it's actually going to land after, because I know, Kim, your team kind of went through all the comments. Joss, I'm sure on the Da Vinci side, you guys did as well. So Kim, I'm going to start with you on this one. What was in the proposed rule or comments that made, kind of caught your interest or maybe raised your eyebrows a little bit? If you want to comment on that.
Yeah, happy to. And Josh reminds me all the time, it's not just about prior authorization. I call it the PA rule. It's so much more.
Much broader.
It is so much more, but she knows I'm a PA buff and I want to see prior authorization resolved and get us to a more streamlined fashion of helping patients figure out, their treatment and what they're going to be covered for and get to that more expeditiously. And I think we can. And I think this rule is one of those key pieces to help move it, but it does contain, a lot more about clinical data exchange and what needs to be done and what needs to be utilized to make that happen, from payer to payer to provider to provider to provider to patient access APIs to the PAR D or prior authorization, API exchange using the Da Vinci implementation guides, right? So, not surprised when the rule came out and started calling for recommendations for use of, APIs and, the FHIR-based APIs and the work that has come out of, again, Da Vinci. I know the Codex use case, which I lead for prior authorization, we're leaning into that and going ahead and getting ahead or trying to get ahead of implementing those implementation guides to do prior authorization. And it's going really well and given the ecosystem that we have right now and the data availability in the systems. But, I really was, Jocelyn mentioned this earlier, right? We had the 57 come out, but we also had the attachments in VRM come out not shortly thereafter. And just the starkness of comments between the two, not only the type of comments, but the volume of comments on the CMS improving interoperability and prior authorization rule was just statistically great. Whereas, the attachment rule was pretty low. But, we found that, in our assessment, right, that overall, roughly 68%, I'll repeat what we had talked about in our webinar some months ago, 68% overall agreed with the intent of the rule. There were some specific concerns like HIPAA related concerns, but very few actually disagreed with the rule overall. Which I found interesting, and that 95% of the providers, not shockingly, they wanted more efficiency. They want quicker turnaround times. They want to have more transparency, right, into why a treatment or why a course of treatment might have been denied or partially denied. So they're looking for that streamlined information as well. And again, I know I'm focusing on the PA part, but I love that part. But as a patient, I like also that there was patient access API, more information related into that more information is going to have to be put into the patient's access API that is required to be stand up by payers. So patients have more transparency into their healthcare, including determinations about their care that are being done between the provider community and the payer community. So those were definitely a couple of big things that stood out for me from that NPRM. What about you, Joss?
Oh my gosh. So So I think it's really good that Kim acknowledges and has identified her bias. So that's really good. The first step. Right. So I have my own bias I'm going to disclose because I have what we call a specialty medication soapbox I like to get on. And I think that one of the things that was frustrating to me in the current rule, although I adore my Oberry High colleagues, and I know that this is a really sticky wicket to get through, is really clearly trying to figure out how we are going to provide relief for people that are trying to get automation around specialty medications, because it's largely left out of the rule as it was proposed. And so I'm really hoping to see some relief for that so that we don't end up with this hole that people can work around, not having to automate things that are on medical benefit and are high cost drugs or infusions that will be considered out of scope or could be interpreted as out of scope for folks who don't want to move forward with automation and need the stick, right, instead of the carrot. I'm going to tell you one of the things that made me really happy was the inclusion and reference around attribution in the front matter of the rule, and that it was a nice little surprise that the CMS team acknowledged the role of the Da Vinci attribution guide, because we found everybody picking up to adopt FHIR in general doesn't really think about how they're deciding how they're matching. And that so for places where there is an established relationship between a payer and a provider or trading partners, that there's a tool out there. And so that was a really great boost. And we've seen a lot of maturity and adoption and people picking up that attribution guide this year. I think it gave some great focus, which is awesome from because it's a building block, right? So much is like getting started and making sure you have the right building block. And the other thing I was surprised about is that it wasn't staggered. We really expected from the Da Vinci community perspective, and I would say have given some pretty strong opinions over the past couple of years to our all of our HHS colleagues, ONC and CMS alike, about really making sure that we allow people to have incremental progress. So we were surprised that everything was pegged at that 2026 deadline. And I think that I want to call this out because I think it's important. I get to see a different side of the world, both with our consulting hats on and my role in Da Vinci, which is, I think it took the air out of people that were making intentional progress on things like payer to payer or provider, payer to provider workflows building on patient access API. And I think it provided buffer for people that haven't been compliant with patient access API. That it stole some momentum, I think, from the industry for it to get pushed to 2026, because when we look at how funding models work and how a lot of organizations get their money, right, to do these projects, 2026 is an eternity away at the end of 2022. So I'm really hoping to see some more realism from a staggering perspective going forward. There's so much built into these rules. People really need to have their house in order because there's just a lot that's going to need to be done well beyond sort of just the adoption of a technology layer and an API service, right? And I'm sure we'll unpack that as we get further along. So, but those were sort of my sort of takeaways. But I have this funny field experience reading the comments themselves. Do I like them? So I was thrilled, and the stats that Kim just put out about sort of the positive response to me is we're ready. There's a vacuum here. We need to fix these problems for payers and providers so people can focus on the important stuff, caring for patients.
Yeah, I'm glad you called out the specialty medications. That's one thing that I think you and and the surprising thing is, I think people in industry we're kind of going back to that. I mean, we put together slides a couple of years ago that I've dusted off in the past 3 months because all of a sudden people are like, wait, you can't, specialty medication, was it right? Exactly. Yeah. Bring out the soapbox, bring out the slides. Let's start, So, it will be interesting to see, because I know I think a couple people must have commented on that. And, why leave them out? I think it's such an important piece, right? And we do see that as kind of the longest piece when it comes to medications and getting that prior authorization. So there's no reason that if it's covered under the medical benefit, it shouldn't be included. So great call out. All right. So now that we've given our audience a bit of a reminder of what was in the proposed rule, let's talk a little bit about kind of when the rule drops and what's going to happen. And I know both of you are going to dig into the final rule, whether it drops before the holidays or right after the holidays. So if you were going to give advice to our listeners on maybe some of the keywords you'd use to search the final rule, what would they be? Trivia. Here we go. Josh, I'm going to start with you on this one.
It's going to be so painfully transparent in what I'm going to do. The first thing I'm going to do is I'm going to keyword search on the words Da Vinci
Yep.
and the entire rule to see how many times it's mentioned. And then I'm going to move to the IGs. So, I mean, painfully transparent. That's it's going to be like, where are we included? Where are we not included? But I think overall, I think that that timeline is one of the things that folks are going to look at. And I think taking the time to do a really good skim of the front matter of the sort of the scoping sort of section before it actually gets into the body of the rule, I think is a really good best practice for folks to really think about. I don't know, to me, I think that, if you just went through the conversation that we had, right, payer to payer, what's in prior authorization and the timelines, I think are probably going to be the biggest thing that I'll focus on for that first half at reading. And then we'll joke about how much of the actual detail reading I'll do versus relying on my friend Kim to just point out sections for me to go and interpret.
That's exactly what I do. So Kim, what's your approach? She's like sitting there reading.
First and foremost, I'm going to break out the eggnog.
Yeah.
Okay, no, just
is it whiskey or rum?
Yeah,
both?
Whiskey. It's got to be whiskey all the way. Brown liquor girl. But no, in all seriousness, I'm looking. How weird is this? I'm really looking forward to it because I think it's long overdue.
Yeah.
But as Jocelyn said, I think the timelines, we didn't really talk about that. We were talking about kind of what we were surprised by. There wasn't a staggering. I think the only staggering really was the Medicaid exemptions, and that Medicaid was going to has an opportunity to be exempted for a year, then potentially another exception for a year. It'll be interesting to see if that remains. I think it will, but I'll definitely look for that. But timeline variances, any shifts, right, in requirements for use of the standards. So, what Jocelyn was just saying, I'm gonna look for the standards language first and see what's still out there and what's not. Did something shift from that? I also think any new, additional references to TEFCA. We talked about TEFCA earlier. I think there were 5 requests for information in that rule as well that, again, I didn't mention earlier, but I'll mention now, right? And, accelerating the adoption of social risk factors as an example, what we're going to be people's thoughts about that, and considering the social factors that we have in healthcare today and that many are focused on. They also talked about maternal health, which came out during COVID as well, right? And coverage for maternal health. So what will be the responses to that? I'll look for that. But definitely TEFCA, any references to TEFCA and the continuation of improving that ecosystem with FHIR, I think will definitely be part of what I'll read through. But got to look for prior authorization. That should have been the first thing I said was prior authorization out of the gate. But really timeline, I'd like to see if the timeline shifted in some way, because I think that will also help us as we help others that we consult with on, where are they at in their roadmap and get realistic about it. If they haven't already, and I sure hope many have. I know several that we have gotten pretty aggressive about that. I think it will also help me in the Codex conversation with the members who are there and trying to progress, prostate cancer prior authorization. So yeah, that's what I'll look for.
Good. Well, I know it's just a waiting game now, and final rule may drop a week or 2 weeks or longer after this episode airs. So hope we gave some folks, some of our listeners, some good reminders of not only what was in the proposed rule, but kind of how to approach reviewing the final rule when it drops. And I love the idea of the eggnog. So that's a great one. All right. So let's close out this episode by going around and really sharing what we hope to see happen or work we hope that makes some more progress in 2024, and just any other final thoughts. So Joss, I'm going to start with you, and then Kim, you go after Joss.
So I'm going to say, I just am so thankful for getting to work with you guys and all the other people I get to work with. It's really, it's a privilege to get to do the work that we get to do. and sort of the influence that we help drive in the industry to move the industry forward. I mean, I think that you could hear the themes of transparency, right? We need to give better tools to providers and to our payer partners and to the vendors that support them in the industry, right? So we as consumers have more transparency about how we're going to navigate, individual care journeys. And I think that's important. Second, I'm going to say in 2024, I was just working on my year-end slides for Da Vinci. And to me, it's, I'm a broken record. Like this is an exercise in, who and how are you going to get this work done? This is happening, right? And so, if you don't have a plan or you haven't picked your partners, you don't know what your requirements are, you haven't done the work to scope out what your projects would look like or who's going to be on your team to respond to this and the many other regs that we did not talk about today, right? We didn't talk about HTI-1 in detail. We didn't talk about, some of the skinny but powerful rules we saw around information blocking. I think we're going to start to see enforcement next year, right? I think that the ONC and CMS are going to start going out as these rules are out there and, starting to pick who they're going to, have enforcement with. And I think that is going to make people move faster and that this work that we're doing is so much more than just technology. This is really about business transformation and how are you fundamentally setting up how you are going to work with your partners, whether it be providers to payers or pharmacy or other community members, and the right data flowing, including all that really rich SUH data and SOCI data that we need to collect so that we can care for people and get them the services that they need. And we have to educate and build the people to do this work. People aren't out there. We're learning as we go, right? All of us collectively from our experience. You're not going to be able to go and hire people off the street to do this work. This really is an exercise in investing and building the people to do this work and have your game plan about how you're going to get it done. So I would say I'm really looking forward to others coming to join us. The water's warm. We're all learning together. There is no right answer, I think, at this point in time. And so I really more and more real world implementation. And I'm going to make a note that Kim said something that I'm reacting to, which is, I think that we have the federal landscape and, I see that a lot of states are moving to action. And I think even if the CMS timelines are further out than we anticipate, we've seen Washington and California, and there's activity happening in Mass and in Utah. I think we're going to see the states not provide the relief for those Medicaid, plans and organizations. And the states are going to be bullish and move faster, I think, in some places than our federal partners. So I'm looking forward to see what becomes real from an implementation standpoint in 2024.
Hey, Kim, thoughts on 2024?
I think 2024 is going to encapsulate all of what we've talked about already and more. I do think that, to Jocelyn's point, I think we're going to see more and more come out from the Office of National Coordinator and rulemaking around certification processes. We talked about pharmacy interoperability. We didn't talk about the CY25 rule that's got real-time prescription benefit and a new script standard, right? And they've held off doing any particular rulemaking around certification for those two technologies or those two standards and their implementation. But Jocelyn, you just hit on it, right? States are also doing a lot of stuff. I just saw a Wisconsin bill come through where they're going to take $500,000 each fiscal year to empower the adoption of real-time prescription benefit tools in Wisconsin. Right. And they're going to put their money where their mouth is to kind of help move these innovations and these patient empowerment solutions to fruition where we've seen it lagging. So, 2024 ONC, big time, additional CMS rules coming out on other parts of the ecosystem like e-prescribing. There's a Support Act 2.0 out there and the focus on opioid use disorders. I think we're going to see a lot of activity there. But, AI, we talked about it earlier. We're going to see more and more AI. I think we're going to see some states come out with some more specific details relative to the use of artificial intelligence in healthcare. I think privacy and security are going to be a big component of that. We, of course, would be remiss if we didn't mention the go live for TEFCA, right? How is that going to play out in the first 6 months? or so of 2024. And, you know, we're on it, we're focused on it, and we're watching it, and not only watching it, but engaged in it. I mean, Pooja was just on a panel, right, at Sequoia and talking about really smart stuff. And we have a lot of folks within our midst who are on it every single day and helping organizations figure out how to traverse the path. And focus on, you know, go-to-market strategies based on what is in front of them, either competitively or through the policy landscape, and they go hand in hand. I think we're going to see some additional consolidations within healthcare that are going to play a big role in how we interoperate and how patients receive care. And I just think there's a lot ahead for us, really smart stuff that can happen. But you need to stay on top of it, and it's something that you got to stay on top of every day. And we're here to help you be empowered by that, and you know, hope that what we see come to fruition is nothing but positive.
Great. Thanks, Joss. Thanks, Kim. And just to add to what you guys said, I think 2024, you know, I said this earlier, pharmacy interoperability, right? I think what we saw these last 2 quarters was really kind of the recommendations that came out from HITAC that said we need to bring in pharmacists, you know, we need to bring in pharmacy to the table. I think the Sequoia at the annual conference, you know, we kind of stood on stages and said, don't forget pharmacists, right? And so there's already kind of talk swirling of maybe a pharmacy work group under the Sequoia project. And I think a lot of our recommendations that came out of the HITAC committee was really just kind of bringing stakeholders together to focus on different topics. So I think my kind of, you know, 2024 final thoughts is, like Josh said, right? Like, join us. I think there's a lot of people that have a lot of great knowledge on the pharmacy side and real kind of hands-on experience with pharmacy interoperability. And we really need you guys to kind of step up, right, and bring that knowledge forward to make sure that we're including that. So that's kind of my what I think is going to come in 2024. So, all right. Well, as we end this episode, our last episode, I should say, of 2023, I just want to thank my wonderful colleagues, Jocelyn Keegan and Kim Boyd, for joining me today. And thanks to our audience for listening to the Dish on Health IT. You know, this year we had a lot of support from you all, and truly that means everything. So just a friendly reminder to new listeners, you can find us on Apple Podcasts, Spotify, or really whatever platform you use to pick up your podcast, including the Healthcare Now radio and the podcast channel. We also post videos of our chats on the Point of Care Partners YouTube channel, which is also on our website. So thank you to everyone for who listened to episodes this year, who joined us, and we're really looking forward to joining you all in 2024. And remember, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.